Yeah, over to you, Dr. Panchal.
Fine, and thank you. And again, I warmly welcome you all for this World Congress of Diabetes, being from our organizing committee. And of course, I have nothing to disclose here, but yes, I would expect and we would ensure that next 30 minutes we will discuss only clinically proven science, no assumptions. Since long we are, you know, since I started diabetology, I think 2014, I talk about percentage of people uncontrolled diabetes remaining the same. 2019, the same. 2022, same. Only 30 to 35% of the people are having HbA1c of 7% or less. Yeah, when it comes to the elderly population, I think almost all of us would agree that out of our clinical practice, more than 30% is of having elderly population, that is around 60 plus. Necessity means the need for something. Are all the elder equal? That is the biggest question. Even today, till date, WHO has not defined any age criteria for elder. WHO in their article of aging in abuse, they are using some ageism scale. Different societies are using different cutoff as far as age is concerned, and different classification to classify the elder. So elderly is a big term. When it is said elderly, that means it should be restricted to the elderly with good health. Otherwise it has to be specified, that is frail elder. And that is what I think, from the starting we have been going through, how we can help our elders with diabetes to get good glycemic control and very good quality of life. Whenever it comes in the terms with the use of SGLT inhibitor, I think we will discuss on the balance of benefit and risk. Benefit, of course, if we talk about SGLT inhibitor, reduction in HbA1c, reduction in blood pressure, reduction in CV death, reduction in MACE, reduction in hospitalization due to heart failure, reduction in all-cause mortality. And this all reduction is not restricted to only younger population. This is also required in elder population. But yeah, there is some risk of urogenital infection, risk of hypoglycemia very low in SGLT2 inhibitor. Volume depletion, bone fracture, decay. I think bone fracture, which has almost clear with, showing us very innocent SGL2 inhibitors also. This is a complex pathway through which SGL2 inhibitor help all of us, including our elders, and these are the various other OHA also, and where they are used in the terms of elders. I will come to SGLT2 inhibitors, and you can see that all the SGLT2 inhibitors from their randomized control trial, even in elderly, if you see more than 65 year, more than 75 year, they are showing benefit. If you take age wise, again I am showing this cutoff, again it is showing benefit in elderly. Now, elderly versus non-elderly SGLT2 inhibitor, and what it says that there is no significant difference noted in the terms of reduction in FBS, blood pressure, as well as overall side effect, overall adverse event in elderly also. So if you think that you can give SGLT2 inhibitor in younger than elderly also, we have the proof. In frail older adult with or without type 2 diabetes, again, one of the beautiful sentence in abstract, I'm sorry, I think it's very, low font. Despite favorable clinical trial data, there has been some resistance in clinical practice for prescribing this drug in older frail adults. Rather than being a treatment to avoid SGLT2 inhibitor, should be considered a valid therapeutic option for older frail adult, and that is what is said in this article. Frail older people with type 2 diabetes and heart failure, again the risk of decay, which I think will become on me, that is risk of decay, acute kidney injury, they are not significant even in the frail older with type 2 diabetes and heart failure. Now coming to the real world evidence, there is a real world safety profile of SGLT2 inhibitor in the age more than or equal to 75 years. Again, in the global post-marketing survey, none of the adverse event was reported more frequently among the older adult. Our finding provide reassurance regarding SGLT2 treatment in older adults. This is a Mayo Clinic and their own data, and particularly in the high risk population. When it comes to SGLT2 inhibitor, it comes there will be volume depletion, there is increased risk of stroke and all that thing. And they have found it in type 2 diabetes with the history of prior stroke. Again, they said that SGLT2 inhibitor and TZD with people with type 2 diabetes and prior stroke was associated with reduced risk of MACE. So their benefit is always there. This beautiful slide ADA 2025, and look at the medication. It should reduce the treatment burden, of course. SGLT2 inhibitor can do it. Affordability, nowadays it's not the issue. End organ protection, it is there with SGLT2 inhibitors. Polypharmacy, we have FDCs available with SGLT2 inhibitors. History of adverse medication, I think every medication has their own contraindication. You should not go with that. But in general, for all elder, even ADA says that there is a benefit, and in their guideline, they are including SGLT2 inhibitors even in elder population. This is a European guideline for the diabetes population in old age group. Again, they have put as a second drug of choice SGLT2 inhibitors in their protocol. Particularly, expert consensus statement from Endocrine Society. Here also you can see in healthy adult, healthy elder population, there is an option that you should utilize SGLT2 inhibitor as a second drug. Moderately frail people also, they are recommending you can use and you should use for the end organ protection SGLT2 inhibitors. Even in severely frail people, if there is a risk of heart failure, you should commence or you should continue the SGLT2 inhibitor. This is not my statement, this is a guideline what it says. Our own RSSDA therapeutic will, if you see the A for age, there is SGLT2 inhibitor noted down after metformin. 2022 RSSDI statement, SGLT2 inhibitors recommended for up to 70 years of average weight, obese elder, helpful in patient with diastolic dysfunction. So I would say if I see benefit and risk, of course benefits overweights in the terms of use of SGLT2 inhibitors in the elder population. In at all, if there is some risk, it is due to lack of education. And here I will end to say that glycemic control in elderly by SGLT inhibitor is necessity, not risk for all elder. Thank you.